continuous machine-like murmur, which would be indicative of a patent ductus arteriosus, and we would expect that to close within a few days. So benign unless we don't see improvement within a few days, and then it would have to be worked up further. And any other murmurs or murmurs, especially those that aren't improving within a few days, we'd want to evaluate them further, maybe EKG, echo, involve cardiology, something like that, to work up any other murmurs that may indicate some cardiac pathology. And then with breathing, again, we would just look, see, make sure they're not in distress trying to breathe, just watch the chest wall, how it's moving. I want to see a respiratory rate between 30 and 60. One thing that can freak parents out is irregular breathing or pauses in breathing, which is called periodic breathing and is normal in neonates, but can definitely kind of freak people out if they think their baby has stopped breathing. So want to reassure parents on that if it's present. And then after, and also taking the lungs, seeing that they're clear, all that, then we move on to the abdomen. First looking at the umbilical stump, making sure it's clean and dry, and then if there is an umbilical hernia, around the umbilicus, we'd like to see that you can reduce it by pressing on it. If it can't be reduced, it should resolve on its own. But if it can't be reduced or it feels stuck, it could be incarcerated, and that would require a surgical intervention. So want to get an evaluation by a surgical specialty. And then we would assess the liver and look for any masses in the abdomen. Want to make sure there's not hepatosplenomegaly. Shouldn't really be able to palpate the liver. If it can, just right around where the ribs are. Don't want it any bigger than that. Then looking for any masses, very rare, but could be something like neuroblastoma or Wilms tumor if there's masses present. And just checking that the abdomen is normal, not any exposed bowel, like an omphalocele or bladder exstrophy, anything like that. And then we'll move to the groin, first assessing the femoral impulses here. Want those to be present and strong. If they're weak or absent, it might be indicative of something like coarctation of the aorta. So, if they're weak, to assess that, you could get blood pressures on all the extremities. If coarctation of the aorta is present, you would expect high blood pressures in the upper extremities and low in the lower extremities. And then if it's a female, we're looking at the labia, the clitoris. Those could be enlarged due to maternal hormones at birth, since they'd be exposed to this while they were in mom. And there may even be some discharge or bleeding from the vagina due to those hormones. And then if it's a male, checking the scrotum. If it's enlarged, may be worried about a hydrocele, some fluid around the testes, which should spontaneously resolve on its own. But that's the most common cause of an enlarged scrotum in a newborn male. And then examine the penis. You should see, look for any abnormal curvature and check that the foreskin fully covers the glands. If it doesn't, there could be some issue with the placement of the urethra. Could be hypospadias, something like that, a ventral displacement of that urethra on the penis, which would need to be resolved. And then in all babies, check that the anus is patent, just looking to make sure that they can pass stool, things like that. And that would be it for the groin. Then checking the hips, you can, checking for hip dysplasia, which can happen in neonates. So to check for that, we would do what's called Barlow-Ortolani maneuvers. For Barlow, you adduct the hips and add posterior pressure. That would dislocate the hip, which would be abnormal. It can sometimes be normal in neonates due to laxity to have it displace or dislocate with the Barlow maneuver. Those babies would have to be reevaluated at 4 weeks and followed closely through that time and reassessed with an ultrasound to see if there is hip dysplasia. And so Barlow is abduction, posterior pressure to dislocate the hip, and then Ortolani is folding them to 90 degrees and abducting. And if they were dislocated by Barlow, you'll hear an abnormal clunk, which is reducing the dislocation, and that would be an abnormal finding in Ortolani. With Barlow-Ortolani maneuvers, normally you do not want to hear a clunk, feel any dislocation, anything like that. An abnormal finding, which could indicate hip dysplasia, would be a dislocation with Barlow and a clunk with Ortolani as that dislocation is being reduced. And those would have to be assessed with an ultrasound to check for hip dysplasia. And then we would move on from there to the extremities, checking the fingers and toes. We want 10 fingers and 10 toes. You can see a small skin tag coming off the 5th digit, which is normal in some newborns, called polydactyly type B. And, that can just be familial, something like that. Short would be fingers, short toes would be brachydactyly, and long would be arachnodactyly. If you saw, especially short or especially long fingers or toes on exam. And that would be about it for the extremities. So we would move on to the back. Oh, one thing is, if you see a single palmar crease, just one, it's normal to have more than that, then you might be concerned for Down syndrome. That can be a finding associated with Down syndrome. It's normal it's present in about 1% of the general population, so it doesn't always mean Down syndrome, but it can commonly occur with Down syndrome. So then we would flip the baby over to check the back, looking especially for any blue-gray spots, slate gray nevi, Mongolian spots. Those are normal, would resolve on their own over time. Starting around day 1 or 2, we can see what's called erythema toxicum, and those would be pustules on an erythematous base. Again, a normal kind of rash that newborns can get that should resolve over time on its own. So then we would look at the primal reflexes. We can flip them back over. The first one would be the Moro reflex. So we'll pull the newborn towards us and drop gently into our other hands. And we should see the palms open, or the hands open, the arms extend, and then retract. And that is a normal Moro reflex, which should be present. Then a palmar grasp reflex is normal in neonates. If you press your finger into their palm, they should grasp it. And then a rooting reflex, if you brush their cheek, they should turn and try to suck. That's a natural reflex meant to help with breastfeeding. And that would be about it. After all that, we would swaddle the baby back up and give them back to the parents and thank them for being such a good patient.